Hi, and welcome and thank you to the Community Health Training Alliance to present on a topic that has become, unfortunately, an epidemic nationwide, but has also become an interest of mine as a dietitian, particularly a dietitian that works in the community setting. I have an interest in using nutrition, be it through providing education or creating programs to help treat the health complications that may arise due to food insecurity. So for the next hour, we will be discussing the prevalence of food insecurity, its impact on health complications, as well as on medical costs, and about MANNA'S services and how we have used food as medicine to treat the acute nutritional risks that may arise from long-term food insecurity. So before I start, I would like to make the disclaimer that this presentation was so wonderfully put together by my manager, Nicole Laverty. She is a dietitian as well, and she's the director of nutrition at MANNA, as well as Ann Hoskins Brown, who is our Director of Policy and Institution at MANNA. I myself had added a few slides, but I wanted to give full credit where it is due. So bear with me all, I'm not able to switch to the next slide. There we go. So we begin at defining food insecurity. So according to the USDA, they define food insecurity as a lack of consistent access to enough food for an active, healthy life. So food insecure people are those that at some point during the week literally do not know where their next meal is coming from. Either they cannot afford to buy food or they do not have access to food. And then we have hunger, which is sometimes the result of being food insecure. So hunger is a physiological state. It describes the physical pain and discomfort an individual may experience at the same time while they have the desire to eat. Now this slide breaks down the levels of food security. So food secure individuals are divided into two categories, both high food security and marginal food security. So high food secure individuals have access to food and they're able to purchase a wide variety of foods when they shop. They have no worry on if their food will run out or where their next meal is coming from. Now, individuals with marginal food security may worry about running out of food from time to time. And this may be from, they might not have budgeted correctly for the month, or greater finances may have come up one month compared to others, not allowing as much money to be spent on food. So when that happens, these individuals may limit certain food items they purchase over that lack of money. Now, food insecurity, as you see, is broken down further. You'll notice on the right column that food insecurity is divided into low food security and very low food security. So low food security, which used to be labeled as food insecurity without hunger by the USDA, is the report of reduced quality, variety, or desirability of diet. So there's little or no indication of reduced food intake. This is in the circumstance which an individual might be consuming enough calories to meet their energy needs, but these calories are coming from refined, processed, and calorie-dense foods, which can include fast food items, takeout or convenience items, snack foods, prepackaged meals, or sugary foods and beverages. And they lack calories from nutrient-dense foods, which are considered your fresh fruits and vegetables, lean proteins, and whole grains. And then we have very low food security, which was previously referred to as food insecurity with hunger by the USDA. And that's in which an individual reports multiple incidences of disrupted eating patterns and reduced food intake. So these individuals on average do not consume adequate calories to meet their daily energy needs. They often also might eat smaller meals to kind of get those 3 meals in a day, or they might even go without eating for one day on end. Now, this slide is based off of household reports of those who are food secure, have low food security, and very low food security. And as I mentioned on the previous slide, those individuals who experience that marginal food security do report the occasional worry from time to time about food sufficiency. As they've made the board, you see the top 3 with the worry that their food would run out before they had money to buy more, that the food they bought did not last, and that sometimes they could not afford a balanced meal. And those were seen with the marginal food security, and obviously this was across the board. These claims were made by those who were, these were the top 3, I should say, for low security and very low food security. And you can also see that those with very low food security take up most of this graph, and also reported high incidence of skipping a meal or reducing the size of their meals to kind of stretch out their food. They reported feeling hungry at times, but they still did not eat. They reported weight loss, and sometimes did not eat for an entire day. So food insecurity is a national, statewide, and local issue. And in the state of Pennsylvania, there are 13.1%, that equals 1 in 8 residents who are food insecure, which is pretty comparable to the national average up there of that 13.4%. So in Pennsylvania, this translates to over 1 million people. And to top it off, Pennsylvania's largest food insecure county is Philadelphia, with a rate of 21%, or close to 326,000 people. That means roughly 1 in 5 Philadelphians suffer from food insecurity. What's also worth mentioning is that Philadelphia ranks 10th on Feeding America's top 10 hungriest counties, and Philadelphia has long been the poorest of the 10 most populous US cities. So food insecurity is not just limited to the county of Philadelphia. As you can see, it affects the surrounding counties as well. And although Philadelphia County has the highest rates, Bucks, Chester, Delaware, and Montgomery all have high rates of food insecurity, and it's been increasing over the past several years. And I did just want to point out on this slide, the top line there. I know it's kind of hard to distinguish the blue colors, but that top line is Delaware County and the amount of people participating in SNAP benefits. So you can see since 2012, there's been a steady incline with that, and Delaware County is second among the other surrounding counties with the incidence of food security. And from these maps, it's evident that there is a direct correlation between poverty and food insecurity rates. So the dark red sections of the map on the left depict the sections of the city with high rates of poverty. And you'll notice almost all of the same sections to the map on the right in the dark green show the high rates of participation in SNAP. The main reason Philadelphia has so much hunger is that it has so much poverty. So it has the highest poverty rate of any large US city, with more than a quarter of Philadelphians living under the meager federal poverty line. For example, close to 20,000 annual income for a family of 3. And the main reason that the city has so much poverty, there's just not enough jobs, and the wages are not sufficient enough to make ends meet. Now, each year, the US Census Bureau counts people in poverty with two measures. So both the official and supplemental poverty measures are based on estimates of the level of income needed to cover basic needs. So those who live in households with earnings below those incomes are considered to be in poverty. Some limitations with these calculations include gross income, annual gross income that is, so before taxes are taken out. And these limitations do not vary from state to state, despite the difference in costs of living from state to state. Now, the official poverty rate is 12.7% based on the US Census Bureau's 2016 estimates. That year, an estimated 43.1 million Americans lived in poverty, according to this official measure. And according to the supplemental poverty measure, the poverty rate was about 14%. And I did mention on the previous slide, a quarter of Philadelphians live under the federal poverty line, but take note that 12.3%, so about half of that, live below 50% of the federal poverty line, which is considered deep poverty. So for a family of two, you'll see from the chart there, $16,020 of annual income would be considered at the federal poverty line. So an annual income of maybe $8,000 would place them in that deep poverty line. Food insecurity, as I mentioned, are very correlated, but they're not, and related, but they're not necessarily the same. So meaning is you don't have to live in poverty to be food insecure. Nationally, 26% of food insecure households live above the poverty line. And then we have food deserts. So these are the areas that lack access to affordable fruits, vegetables, whole grains, low-fat dairy, all of which are made up of a balanced and healthy diet. So they are measured by the distance to the store or the numbers of the store in the general area, family income, overall average neighborhood income, vehicle availability, and also the ease and availability of public transportation to and from stores. Many Americans living in rural, minority, or low-income areas are subjected to food deserts and may be unable to access affordable, healthy foods, leaving their diets lacking in those essential nutrients. You may all be familiar with that term, you are what you eat. I know I heard it growing up, but research has actually shown the need to change that phrase into you are where you eat, meaning the neighborhood you live in has a profound impact on the food choices you make. So without access to healthy foods, a nutritious diet and good health can be out of reach. And both of these maps actually come from the Philadelphia Department of Public Health. And I just wanted to point out the red areas on each map. So on the map on the left, those red patches represent areas of no access to healthy foods. And on the right, the red areas represent areas of high poverty. So the areas on each map are not entirely identical, but where you do see overlap, and maybe you can see with my arrow here that I'll take, you do see overlap in certain areas of West Philadelphia. You can see the red patches here and here. North Philadelphia, particularly up here. And then we have lower Northeast Philadelphia where you can see the patches. You'll also notice, I know it's really hard to see, but on the map on the right-hand side, it's in light green. These areas are which there has been improved access to healthy food since 2010. And this map is from 2012. So I'm hoping that, and I'm assuming so, that there are more of these areas throughout the city. Food insecurity can contribute, exacerbate nutritional deficits, and it's linked to chronic diseases and conditions. So this is known from research on all income groups. The high rates of these illnesses in our country are due in part to the fact that healthy, nutritious food is considerably more expensive than food that provides little to no nutritious value, such as those calorie-dense foods or energy-dense foods that I mentioned earlier. So this lack of access to healthy food and nutritious foods over time can lead to high levels of chronic disease. That's diabetes, heart disease, liver disease, certain cancers, asthma, arthritis, COPD, and chronic kidney disease. And what I also wanted to mention with heart disease, these individuals are 60% more likely to develop congestive heart failure or experience a heart attack. We also see medication non-adherence, and I'll make this point again in the slide, but it's so important for any condition, but especially with those living with HIV, in which that medication adherence is essential with antiretroviral therapy, especially in those classes of medications where food is needed to boost the effectiveness. We see poor diabetes self-management. There's a higher probability of mental health illness. And in particular, these people are 3 times higher to develop depression. There have also been some reports of a limitation in an activity of daily living, which kind of leads to diminished capacity of independence. We see higher rates of iron deficiency anemia, and due to all these chronic conditions, we can see more hospitalizations, longer inpatient stays. Now, managing nutritional needs and managing health requires a great deal of balance, and sometimes it can be very, very difficult making choices and spending between a food budget and medical costs. So often individuals and households who are food insecure have to manage their finances at the same time as facing a difficult balance of deciding between a food budget and medical costs. So the image is taken from the above image, the top one, from Feeding America's hunger report, and it breaks down some of those what we call spending trade-offs, in which utilities, housing, transportation, medical, and educational costs were spent over buying nutritious foods. This trade-off can then, over time, lead to high incidences and rates of developing serious or chronic conditions, and the inability to manage those diseases, leading again to higher healthcare costs. And I particularly love this circle on the right. It just clearly captures the never-ending cycle of food insecurity on health. So we begin at the top there with the lack of nutritious food. Again, it's either lack of access to getting food or the inability to afford nutrient-dense foods that will offer the best nutrition for a healthy lifestyle. And this constant state of not knowing where your next meal is coming from in turn leads to stress. And as we all know, when we are stressed, we do not give ourselves the proper care. So for those that are food insecure, the lack of food plus the stress on top of that can lead to increased health complications. So I'd like to paint the picture of, take for example, someone who has type 2 diabetes, a chronic illness that relies heavily on proper diet and medication management. The stress from being food insecure could cause a cascade of events. So this person might spend their money and seek comfort food and like processed dessert items. They might decide to skip meals, or they might decide to spend their money on food this month and neglect their medications. Let's say they're taking an oral medication to help manage their blood sugars. Any of those events over time can lead to increased health complications of poor blood glucose control and the need for more medical attention. And this can be seen in more frequent ER visits, more doctor visits, possibly hospital stays, even more medications. So let's say that this individual, like I said, is only on an oral medication for their diabetes. But with it going uncontrolled, their blood sugar for so long, they might now have to have an insulin regimen on top of that. So in turn, there's more money spent on medical costs and less money spent on nutritious foods. And then we're right back to the start where we're still at a lack of nutritious foods, and this cycle will continue. The bottom line is, if you don't have access to the resources to feed yourself and your family, not only food, but healthy food, your rates of developing chronic illnesses skyrockets. Research has shown incidents of food insecurity leading to a greater risk of becoming overweight and obese, as well as a 50% greater risk of developing diabetes, 20% greater risk of developing hypertension. And I also want to point out that 7 out of 10 Americans who die each year of a chronic illness, most of which is diet related. And it's estimated that the annual health-related costs of hunger and food insecurity in the US is about $160 billion. So malnutrition, what is it? It's where there are either deficiencies, excesses, or imbalances in intake of energy, protein, or other essential nutrients. Most commonly, it's referred to as undernutrition. And again, this is the result of food intake that is continuously insufficient to meet dietary energy requirements. There also might be poor absorption or utilization of food or the nutrients consumed, and it usually results in a loss of body weight. We also have overnutrition, which is a chronic condition where the intake of food exceeds the daily energy requirements and most often can result in overweight or obesity. Now, can we have the double burden of both? So yes, we can. The double burden of malnutrition is characterized by the coexistence of undernutrition along with being overweight or obese. And it can happen in individuals, households, populations, and across the life course. So this double burden of malnutrition can exist at the individual level. For example, take an obese person with possibly an iron deficiency. At the household level, when a mother may be overweight or anemic and a child or grandparent is underweight in the home, and also at a population level, where there's prevalence of both undernutrition and obesity in the same community, nation, or region. So let's talk about food pantries. I would like to bring them up as many of those who do face food insecurity rely heavily on them to provide additional access to food in addition to SNAP or any other benefits they may receive. And although food pantries can be great resources for food insecure individuals and households, often these locations are filled with canned or processed foods, and they lack those essential nutrients that come from those fresh fruits and vegetables, whole grains, and lean proteins. So as a result, individuals who rely heavily on food banks to provide the majority of the foods in their house are at a higher risk for developing chronic diseases. And again, this is just the disclaimer, this is not all food pantries. I know there's a lot of great ones in Philadelphia that actually do offer some fresh produce as well as lean proteins. But for the most part, what you do see is those processed and canned food items. And you'll see on the right panel there that over 50% of households have a member with high blood pressure. 1/3 of households who rely on food pantries have a member with diabetes, and the households with seniors, 50% at least have diabetes, and 75% have hypertension. And American diets in general are out of balance when it comes to following the recommended dietary guidelines and food serving sizes. This issue, again, is exacerbated for individuals who source food from food banks due to low quality of food access. And again, I really like the picture at the bottom right corner. Typically their diets, again, are too low in whole grains. They lack adequate fruit intake. They lack adequate vegetable intake. Most importantly, those vegetables of dark green and orange, which have a lot of vitamins and minerals and antioxidants. Too low in low-fat dairy, and then too high, as I mentioned, again, those, calorie-dense foods that are really high, again, in calories, but those calories are coming from added sugars and fat and have very little nutrition to them. And then we have diabetes. More than 29 million American adults, so more than 29 million American adults have diabetes, and another 86 million have pre-diabetes. I even heard the instance that a lot of Americans, I don't have a number on that, but a lot of Americans are actually living with pre-diabetes and they may not even know it. The CDC projects that 1 in 3 adults could have diabetes by 2050. So more than 1/4 of seniors have diabetes, which equals out to about 11 million seniors. Diabetes is the 7th leading cause of death in the United States, accounting for around $245 billion in medical costs and lost productivity each year. And as you can see from this map, unfortunately, Pennsylvania is among the states that rate the highest in adults diagnosed with diabetes, above 9%. And this is from 2010. So it's safe to assume when the CDC comes out with the most recent data that this map will probably be more heavily covered in that dark red. And diabetes is so highly affected, as I mentioned before, and controlled by diet due to lack of access to healthy foods. Those with diabetes who are food insecure are at a higher risk for hyperglycemia, which is episodes of high blood sugar, but they're also at risk for hypoglycemia, which is low blood sugar. And particularly the hypoglycemia might be an instance where a food insecure individual is taking insulin. And again, maybe their meal is so small, all they have is a couple crackers in the home, which is evidently not a meal. So they might have about 4 or 5 crackers, take their insulin, and that insulin is meant to help act on their meal and help control their blood sugars after a meal. And being as though those 5 crackers are just not enough, there's more insulin to be used in the body, which can plummet the blood sugars. These events can be even more detrimental than the high blood sugars, those episodes. So other dietary concerns of those who are food insecure with diabetes, the energy-dense foods, again, the processed foods, refined grains, added sugars, fat are much cheaper than the nutrient-dense foods. Lower quality diets are less expensive in general to add to that, and food insecurity associated with lower quality diets, lower produce intake, and fewer healthy eating habits. And I also want to bring attention to a longitudinal survey that was done in the US showed that there's a 50% higher risk of diabetes among food insecure adults, as well as food insecure adults are 2 to 3 times more likely to have diabetes than other adults, even after controlling for risk factors such as income, employment status, physical measures, and lifestyle factors. And more food insecure pregnant women are also at a greater risk for developing gestational diabetes. And I also wanted to briefly discuss just on this slide how food insecurity impacts those living with HIV. My role here at MANNA over the last 3.5 years, I've just been working so closely with this population, and it affects them in a great deal as well too. I mentioned earlier that the state of constant food insecurity can lead to stress and poor disease management. So in this population, the added stress from being food insecure can lead to an increased risk of acquiring infection as well as transmitting infection. And as I mentioned earlier too, that poor medication adherence is seen as well from time to time, either being stressed out, taking it or affording it, and this not being able to take their antiretrovirals every day. It's so crucial for those living with HIV. It prevents the virus from multiplying, therefore it protects their immune system and prevents further drug resistance. And if there is poor medication adherence, poor immune outcomes, such as possibly a high viral load, low CD4 count may arise, leading to the increased risk of related infections, and therefore increasing the rate of morbidity and mortality rates. So food insecurity and rising healthcare costs go hand in hand. People with severe food insecurity who struggle the most to put food on the table have healthcare costs more than twice as high as people who are food secure. So the NHIS, the National Health Interview Survey, reported on the connection between food insecurity and medication underuse. And if you are food insecure and need to decide between purchasing food or paying for your medications, you are more likely going to purchase food. So this can have a huge effect on the treatment of diabetes. Particularly, I mentioned, if you're not choosing to purchase your insulin, your oral medication, even your test strips to kind of manage your diabetes. So it then increases occurrences of ER visits and hospitalizations, leading again to increased healthcare costs. So, strategies and solutions. So there are many strategies and resources that do exist to combat food insecurity, but most importantly, what we need to work on combating is the related health issues that might arise. And the best way to do that is through food. So from prevention to treatment, food can serve as medicine, and this graph depicts the food resources and their role in either the prevention, treatment, or somewhere in between of those intensity of the illness and their symptoms. So to start, we'll kind of outline those programs that have been set out for prevention. So we have SNAP, WIC, school lunch program, congregate meals, food pantries and grocery bag programs, and senior home delivered meals. So SNAP, it's the nation's largest nutrition program. It does meet basic food and nutritional needs while maintaining dignity. So it encourages self-sufficiency where people are still able to go out and purchase foods for themselves. Therefore, it redirects money to meet other essential needs such as medications, and it offers choice in what the individual is purchasing for themselves. The benefits of SNAP range anywhere from $15 a month to $192 a month, depending on their qualifications. Now, food pantries, which I mentioned earlier, sometimes can be part of the problem, and that's not all, again. So 70% of the households who use food pantries in Philadelphia have a household member with heart disease, hypertension, diabetes, or high cholesterol. 40% of pantries do not give out fresh produce, and most of these pantries have those processed foods. Mostly it's your enriched wheat products like white bread, white rice, white pasta. And then we have senior home delivered meals, which these programs focus on seniors who are 60 and above, and it's supplemental. So meaning they'll be receiving maybe their dinners for the week, and they might get a couple of snacks, but it doesn't make up a whole day's worth of food. So these individuals will still have to purchase and cook some of their meals on their own. But other recent research on these programs has demonstrated that these meals can sometimes be particularly high in sodium compared to the 2010 dietary guidelines. Foods contributing to this are processed meats, as well as those mixed dishes with a lot of sauces and gravy, which can include chicken teriyaki, beef stroganoff, chili, and gumbo. And there are programs out there as well contributing to disease management, such as prescription fruit and vegetable programs and home delivered grocery bags. So many health centers across the country are adopting those fruit and vegetable RX programs. Some models offer coupons or tokens that can be used at on-site farmers markets. Others are modeled on CSA programs and offer low-cost boxes of fresh produce. I know before I became a dietitian, I participated at Greensgrove Farm. If any of you are familiar, over in the Fishtown area, they participated in a CSA program for SNAP recipients. So these SNAP recipients would use their SNAP benefits to purchase the boxes at a lower cost. And they would also receive nutrition education. So it's all well and good when you do receive a box full of a bunch of produce, but sometimes you just might not know what to do with it. So this program allowed these individuals to not only receive the fresh produce, but learn how to use it, how to store it, how to clean it, which is just wonderful. The Food Trust in Philadelphia also participates in the Philly Food Bucks program. And this is a healthy food incentive program, which again encourages SNAP recipients to use their benefits to purchase fresh local ingredients at these participating farmers market stands throughout the city. Today, food bucks are available at farmers markets statewide. And in Philadelphia, for every $5 spent at any of these farm stands using their SNAP benefits, these customers then receive $2 in food bucks for fresh fruits and vegetables. So it's an incentive for them to come back again to purchase more food. So it increases their purchasing power of farmers market shoppers who use SNAP by 40%, this program. And I want to touch on the home delivered grocery bag programs. They're found throughout the country and are also referred to as brown bag programs. These programs are typically catered to seniors, and through some of my reading, I found that the Meals on Wheels program in San Francisco had a brown bag program in which volunteers would assemble and deliver these grocery bag items for local seniors. And each bag contained food needed to make nutritious meals, also allowed clients to be able to cook for themselves without the burden of maybe getting out to the supermarket. And then we have MANNA. So we're at the end of that graph. Here's where MANNA exists. We provide medically tailored meals as well as nutritional counseling to treat those individuals who have acute nutritional risk, possibly from long-term food insecurity, and also have a chronic condition. So I just want to make clear by this slide, no, MANNA is not treating food insecurity. Again, as I mentioned earlier in these slides, we can see the burden on health, and that's kind of where MANNA steps in to both empower and through the meals and education and teach individuals about their therapeutic diet that they might have to be on, with the goal of helping to improve healthcare outcomes and reduced health costs. And again, that is our mission. It's right in front of you. But again, we are clearly serving those individuals who are suffering from a serious illness, but also at a short-term nutritional risk. We prepare and deliver these meals weekly and also provide nutritional counseling by dietitians on staff here, with the hopes, again, of empowering these individuals to battle their illness and improve the quality of life. So a little bit on the history of MANNA. We are a nonprofit that was founded in 1990, and we were strictly only serving the HIV positive community. This was a time of the AIDS crisis, where a lot of these individuals were being ignored. The meals that we were preparing at that time was to provide comfort and dignity to these individuals who were sadly dying. We didn't have medically nutritious meals at this time. We were, again, providing comfort food and support to those individuals. However, with the improvement of antiretroviral therapy in the late 90s, MANNA then changed, took a good look at the food items they were sending these individuals, and that's kind of when we started creating our therapeutic diets. So meaning we're going to be offering those foods that I mentioned earlier in this presentation, those nutrient-dense foods, more whole grains, more fruits and vegetables, more lean proteins, to help these individuals thrive since they were living longer. And again, that was in the late 90s, we changed our diet. And in 2006, we expanded beyond serving only HIV individuals. We now service those with all serious illnesses. Our top illnesses, in addition to HIV, are cancer, diabetes, heart disease, end-stage kidney disease, and liver disease. So the services that we provide at MANNA are both home-delivered meals, shipped meals, which I'll talk about later, and nutritional counseling. I wanted to also point out how someone is referred to MANNA. So this is a picture of our MANNA referral form. It's easily accessed on our website, or anybody, a client, like as shown on this slide, can self-refer, call in and inquire about our meals, and any one of our staff members can mail this form out to them so they can take it to their medical provider. But we do require that it is filled out by a medical provider. It does not necessarily have to be a doctor. It could also be a nurse, another dietitian, or a medical case manager. So anyone who is overseeing their care. We require the most up-to-date medical information because I mentioned, in addition to having any of the serious illnesses, we are also looking to improve acute nutritional risks that can arise from those illnesses. So that can include significant unintentional weight loss recently due to illness, frequent ER visits, hospitalization greater than 3 days, so a complicated stay, a surgery, start of treatment, specifically cancer or dialysis treatment. And all those questions, I know it's kind of hard to see from this, but we directly ask that. So that is what we are screening for when we receive these referrals. So the clients that do meet those standards are set up on the program for temporary services. They are either set up by any of our dietitians on staff for either 3 months or 6 months of meals. All the meals are prepared at Manna. They are packaged frozen, and then they are delivered frozen to the clients. So all they need to do is keep it in their freezer, and they can easily heat up the meals when they are ready to eat them, either in a microwave or oven. There are 11 different diet modifications. So I did mention we are medically tailoring these meals to meet certain chronic conditions, and each client can have up to 3 modifications, which are selected by the dietitian. As I mentioned, we also provide free nutritional counseling, and we do have in our Department of Client Services here, myself included, we have 4 dietitians, all of which are licensed in the state of Pennsylvania and also accredited by the Academy of Nutrition and Dietetics. So our hope is with the meals and diet education, again, we are just empowering these individuals, teaching them about their diet and getting them back to health. I also want to add through the meals that I mentioned earlier that some of the senior programs were supplemental. So the MANNA model is unique in that it meets 100% of our clients' nutritional needs. The clients get a weekly delivery, and at that time they get their breakfast, lunch, and dinner delivered to them. So again, for the week, all of their meals are being met through MANNA. I want to talk about medical nutrition therapy. So I mentioned over and over that the dietitians provide nutritional counseling, but specifically the type of counseling they are providing is medical nutrition therapy. So I wanted to kind of compare medical nutrition therapy versus the standard nutrition education. So nutrition education is more so just the general reinforcement of basic or essential nutrition related knowledge. So for example, that might be using the statement, don't add salt when you're cooking your meals to someone that has hypertension. Whereas medical nutrition therapy requires a lot of questions asked by the dietitian where they can pinpoint the actual nutrition problem. They can then set intervention, education based on that, and also set goals and monitoring for a follow-up appointment. And it's really key in developing lifelong healthy lifestyles. So I kind of want to give an example of the medical nutrition therapy and again, how it differs from nutrition education. So for example, take someone again, I'm going to go back to diabetes, who's diagnosed with type 2 diabetes, and they meet with a dietitian. So through a series of food-related questions that the dietitian might ask at the beginning of the session, the dietitian might identify that this individual just doesn't quite understand which foods are considered carbohydrates, and it's really important to understand which foods are carbohydrates with this illness so they understand how to portion them correctly to manage their blood sugar. So the dietitian then will tailor their intervention and education to provide really specific education to the client on identifying those carbohydrate foods and how to portion them appropriately to manage their diabetes. And then we'll set appropriate dietary goals for a follow-up so that education is then reinforced. So it really involves an in-depth, individualized nutrition assessment and education to manage disease. And it typically consists of more than one session between the dietitian and the patient, again, where the RD is identifying a nutritional diagnosis, providing intervention, and setting goals and standards to monitor and evaluate the client for a later time. All of which are practices used by the Academy of Nutrition and Dietetics and their protocol. And as I mentioned earlier, I'm not going to repeat too much, but all the meals are cooked here at MANNA, prepared fresh, delivered frozen. Each client gets a welcome booklet that not only has the general information of MANNA, such as our phone numbers and heating instructions, but there's also even nutrition education in our booklet, specifically on different recommendations for each diet, like following a heart-healthy diet, following a renal diet, and then the RDs also counsel clients and determine the appropriate diet using MANNA'S diet modifications. So MANNA is really unique in that it addresses the multiple nutritional issues and concerns of our clients by sending, again, those medically tailored meals. MANNA resourced the leading national nutrition guidelines, and they're all pictured over there on the right-hand side when we developed our 6-week cycle menu. So it was a heavy collaboration between the dietitians on staff as well as the chefs here at MANNA. We actually, a couple weeks ago, revamped our 6-week cycle menu and added a couple of new items, some more plant-based proteins, another type of ancient grains in there, more whole grain options. So the main focus, though, was spent on looking at making sure we're following healthy portion sizes as well, sodium levels, carbohydrate contents, potassium and phosphorus levels, and providing that balance of protein, grains, fruits, and vegetables in the meals we send. And that leads us to our 11 different diet modifications. As I mentioned, we have 11, but each person that is on the program can have only up to 3 modifications, all of which are color-coded. As you see the dots on the right-hand side, we use those dots to label the client's bags. So the most important ones that I want to highlight, we have our red dot, which is our diabetic and heart healthy diet. We have a high protein diet in which our clients receive 21 meals, but they also receive a high protein snack and supplement. We have a Cisco protein shake that they also get. They get 7, so 1 a day to add those extra calories needed, which particularly really important for those that might be underweight or undergoing cancer treatment. We have a low lactose diet for those that might have a lactose intolerance. Our black diet, most important diet for those undergoing dialysis. We're really with this diet watching the amount of sodium, potassium, and phosphorus that we give to these clients since their kidneys are no longer able to filter out those nutrients as well. We have our soft diet. It's not meant to be confused with a typical mechanical soft diet that you might see in the healthcare setting. It's more so for those that might have dentures or have missing teeth. This diet provides, the meats are more chopped up, so there's that ease of chewing for these individuals. We have a pureed diet in which all the meals that we make here are then put through a processor and to pureed consistency, which is appropriate for those with any type of dysphagia or other chewing or swallowing difficulties. We have a purple dot, which is our low fiber and mild spice diet. And then we have orange, pink, and brown, which is no pork, no seafood, no beef, more so for either religious preference or personal preference. And then we have our blue dot, which really it's not a child-friendly menu. We are working into that. It's really just our standard menu and it's half-size portions. So I wanted to briefly talk about MANNA'S research. So these are kind of the steps with MANNA. A client is referred to MANNA. The dietitians here screen them to see if they meet our qualifications. They provide an intake and set them up with services and offer free nutritional counseling. On top of the counseling, if the client is interested in counseling, they receive their appropriate meals delivered once a week. And then we see improved health outcomes and an increased knowledge of their diet. And this is kind of what drove MANNA to do their research, to really capture that impact of food as medicine on the MANNA model, on our clients' health, and on reducing costs in the healthcare system. And this was way before I came on to MANNA, but it's just profound. So in 2011, MANNA set off to complete a pilot study to compare key healthcare costs of our clients compared to a control group. The pilot study was conducted by Philadelphia-based OMG, Center for Collaborative Learning, and this pilot study tracked average monthly healthcare expenditures of 65 MANNA clients during the year before they received service and during the service period. Those costs were then compared with a group of 633 individuals who received coverage through a local MCO, were matched for comparable health and demographics and who had health claims during the same period. And the results provide statistical evidence that critically ill and nutritionally at-risk people served by MANNA incur lower healthcare costs than similar people who do not receive this service. So some of the main results included decreased average monthly healthcare costs, decreased number of average monthly visits to the hospital and length of stay, inpatient hospitalization costs were reduced, and clients were most likely to go home if they were in the hospital rather than a skilled nursing facility or rehab center. And then this graph kind of shows the overall healthcare costs during the 6 months before and after clients began receiving MANNA'S services. So the average monthly cost varied widely, ranging from, as you see, $20,000 to $60,000. And the average monthly healthcare costs in the 6 months following initiation of MANNA was about $28,000 and was considerably lower than the average in the 6 months prior, which was about $39,000. So costs declined most markedly during the first 3 months after receiving the meals, falling 62%. And a lot of these individuals in the study were HIV clients. So we saw average monthly costs among those with HIV and AIDS improve. So the overall range before starting MANNA was much higher, and it ranged from $50,000 to $90,000. The decline in cost was even more dramatic, as you see on the panel on the right there, going from an average of $50,000 per month prior to receiving MANNA to $17,000 per month following initiation of services. And total costs fell by 80% during the first 3 months of service. And lastly, the average monthly costs for inpatient hospitalizations decreased from $174,000 to about $121,000 per month. Average monthly costs declined sharply in the first 3 months of starting the program, from over $178,000 in month 0 to $18,000 in month 3, a decrease of about 90%. Costs, as you see, did increase then sharply from month 3 to 5, but did decrease back down after being on month 5 to 6. So in conclusion, this study represents a comparative analysis of the impact of the MANNA meal program on healthcare costs and utilization of healthcare services. It provided statistically significant evidence of a younger population that wasn't previously looked at. The findings were consistent with prior research that nutrition is an integral part of disease management and suggests an improvement in health outcomes, quality of life, and other cost savings. MANNA'S meal program has a positive impact for the clients that we serve, and the results will hopefully present a strong claim for future research. And from this research, it led to our partnerships with the different Medicaid organizations in Pennsylvania. When I came on in 2015, we were at the start of this, where we signed a contract with Health Partners, in which they would refer members to MANNA. We would provide 6 weeks of service of our meals with one referral and nutrition education by a dietitian. The growth of this and the positive outcomes from Health Partners kind of opened the doors for other insurance companies, such as Keystone First, United Healthcare, as well as Aetna. And with Aetna in particular, we partner with them to now ship our meals across the state to the certain members that they refer to us. So these clients still receive 21 frozen meals delivered to them through FedEx. So we are now, as you can see in the green, that is our delivery area by driving, and the blue area is our expanded service area throughout the state of Pennsylvania. Okay, so I will open the floor to questions. I will answer them to the best of my ability. So yeah, thank you all again for letting me host this.
Wonderful. Can you hear me?
I can.
Wonderful. Thank you so much, Tanya. That was really informative. We got some really good questions here. The first one is, how has nutritional programs catered to minorities, for example, Asians and Hispanics who have specific cultural diets?
That is a really good question, and one that I'm not too familiar with to speak on. To be honest, I'm not really familiar with any of the food programming in Philadelphia that kind of caters to specific diets. But it's definitely something I could research and get back to Kyle, who can pass that on.
Absolutely, absolutely. And definitely working in a city like Philadelphia, where there are so many folks here, I think there's definitely other organizations that we could probably reach out to.
Sure. And I'm more than certain, because I know some of the Asian, the highly populated Asian areas in Philadelphia tend to be South Philly. Mm-hmm. So I'm more than confident that there'll probably be some, smaller food programs or even food banks that kind of cater to their specific needs.
Absolutely, absolutely. And another question is, what exactly are ancient grains?
Okay, so ancient grains are kind of the grains that we cultivated and grew years ago. That's how we get the term ancient. So that kind of consists of and their grains we haven't been eating as Americans up until this big popular surge of them. So they're considered to be like quinoa, couscous, bulgur, kasha, which they provide a lot of dense, in addition to fiber, other B vitamins that you don't really see with the enriched white pasta, or even some of the whole grain pastas out there.
Gotcha. That's wonderful. Yeah, and definitely I will speak to the ancient grains question. There was a period of time where I actually had no clue what an ancient grain was until I got a little bit of food education. So my question to that is just kind of a follow-up. How do you work with folks who are so accustomed to eating one way and, maybe aren't familiar with something like ancient grains?
So it's kind of, introducing these foods slowly. Mm-hmm. Like I mentioned, this took over a year, this new menu planning at MANNA. So it's kind of like this slow introduction of these menu items. And it's kind of more so, it's such a benefit that we have dietitians on staff who can answer these questions and kind of provide the knowledge of why these foods are beneficial to health as kind of a reinforcement. So I believe it's the slow introduction as well as the education that's available to the clients.
Wonderful, wonderful. And just it looks like there's some follow-up from the individual who asked the question about specific to specific minorities. They mentioned that Jefferson has a program for the Asian population. So it looks like there may be some linkage that could possibly take place from this webinar, which is great. From Dr. Marilyn Martinez, I see.
Okay.
So definitely, we're definitely gonna possibly make some connections here today, which is wonderful. So.
Awesome. What is does the program have a specific name at Jefferson, or?
Looks like it's from the Greater Philadelphia Health Action over there at Jefferson.
Okay.
So
Great.
wonderful, wonderful. This is wonderful. Cool. And they said they can send info. This is great.
Awesome.
Wonderful. Look at that.
I like learning from these things too.
Which is wonderful. This is why we do these webinars, so we could get information out there and also connect folks, which is wonderful. Resource linkage is always a great benefit of this. So on that note, Tanya, is there anything else, any parting messages you want to leave our viewers with before we depart?
No, I thank you again all for having me. This is just an issue that's near and dear to my heart and in the work I do here at MANNA. So again, just thank you all for having me speak to you today. Wonderful,
wonderful. And we want to remind everyone that there will be a survey sent out as well as a certificate of participation. And Dr. Martinez, we're definitely going to connect you guys. So thank you so much, everyone, for participating. Thank you for all the questions. And thank you, Tanya, for facilitating this wonderful webinar.
You're very welcome.
Thank you. Have a good one.
Bye.